Alors, est-ce que vous entendez bien?
Oui, oui, c'est bon, madame.
Ok. On va commencer dans 5 minutes. I will start now. Alors, on est le 14 octobre, 8h30, heure de Maurice. Avant qu'on commence, y a-t-il des questions par rapport à ce qu'on a fait? Unit, c'est-à-dire Sexuality and Health, Unit 1, 2 and 4. Et c'est-à-dire tout le monde a reçu votre point. C'est-à-dire j'ai envoyé tous les points pour Sexuality and Health. Tout a été corrigé. Est-ce que vous avez besoin d'éclaircissement ou vous avez des questions par rapport à l'assignment?
Madame, sur les écomaps, on peut passer dessus?
Pardon?
Sur le écomap.
D'accord. Écomap of case study?
Non, pas vraiment.
Ah, ça veut dire écomap, ça c'est clinical social work.
Oui. Ah oui, c'est...
Moi aussi, je suis en pleine correction de votre assignment clinical social work. Donc, on va venir dessus parce que il y a certains qui n'ont pas encore soumis, c'est-à-dire those who are retaking the paper. Et aujourd'hui, là, vous allez voir dans Blackboard, sous Assignment Case Study, you will see the rubric. C'est-à-dire, vous avez vu dans les feedbacks, j'ai mis Refer to Rubric, c'est-à-dire la rubrique, c'est maintenant que vous allez avoir accès. J'ai attendu que tout le monde m'envoie les assignments, même ceux qui reprennent le papier. Comme ça, it's like a reference to what's expected in the answer. Et donc maintenant, vous avez accès à ça pour voir les commentaires que j'ai mis par rapport à le case study. La question était d'appliquer le narrative therapy and how far you have applied it. Donc, pour aujourd'hui, dans Clinical Social Work, on ne va pas passer sur ECOMAP parce que j'ai pas encore tout reçu. Et ce sera pour la prochaine session. To be fair with everyone. Parce que si je commande dessus et que certains de vos camarades n'ont pas encore envoyé le document, donc ce ne sera pas juste pour tout le monde. Sinon, pas de questions sur les 3 units. Unit 1, 2 and 4. Donc, aujourd'hui, on fait Unit 3. Donc, vous voyez bien l'écran Sexuality and Health. Aujourd'hui, on fait Unit 3, Sexuality, Health, Interventions. Ce chapitre-là, c'est plus par rapport aux contraceptions, méthodes de se protéger, donc safe practices. With regards to sexuality, on va faire un petit peu ce qu'il y a dans le manuel et par la suite aussi travailler sur des questions. Et suite à ça, on va faire une petite révision en posant des questions sur ce qu'on a fait, c'est-à-dire dans les sessions précédentes. Donc, sexual health. Si on se réfère à votre manuel, c'est quoi le sexual health? Donc, according to the WHO, what's considered as sexual health? It's your physical, emotional, mental, and social well-being in relation to sexuality. Donc, vous voyez, it encompasses more than sexuality. It's about your physical, about your emotional, mental, and social well-being in relation to sexuality. Donc, ça englobe un petit peu tout. C'est-à-dire, c'est la santé par rapport à la sexualité, c'est la santé émotionnelle, physique, mentale, sociale. C'est pas juste l'absence de absence of diseases or dysfunction or impairment. It's not just about. It's more about a positive and respective approach to sexuality and sexual relationships. It's the possibility of having a pleasurable, safe sexual experiences free from force, free from discrimination and violence. It's respectful sexual rights. Donc, comme vous pouvez voir, sexual health, ça englobe plein de choses. C'est pas juste l'absence de maladie, mais c'est par rapport à le respect de l'autre, le respect de la différence. Respect for each other's diverse sexual needs. C'est comprendre l'autre, c'est l'acceptation, c'est le consentement, c'est, on va dire la tolérance, même si certains n'aiment pas ce mot tolérance-là, parce que tolérer, ça veut dire accepter malgré soi. Donc, sexual health englobes many things. Si on peut prendre ça comme on a continuum line, it's not just being healthy or not healthy, it's how far on the continuum line are we sexually healthy. Peut-être physically it's okay, but emotionally, because we are not who we are, par exemple, pour les LGBTQIA who cannot express themselves, who cannot be themselves in their society. Donc, ils doivent se forcer à être une autre personne parmi leurs amis ou leurs collègues. Donc, how far are they healthy sexually? Donc, in this unit, we talk about contraception, the different methods of contraception. Donc, basically, there are 4 methods of contraception. That's how you will recall if you have to revise this chapter. It's easy to revise. Just know that there are 4 methods of contraception. Et il y a différents types. Sous ces 4 methods, there are different types of contraception. Par exemple, le behavioral method. C'est quoi le behavioral method? It's about changing our behaviors to protect ourselves or to prevent any pregnancy, unwanted pregnancy. Donc, behavioral methods, it's about changing our behaviors like abstinence, intercourse, withdrawal, or fertility awareness. This falls under behavioral methods. Et puis, il y a le barrier method. Donc, dans le moment, ça vous explique le barrier method. It's about male condoms, female condoms, spermicides, and cervical barriers. Et puis, they are hormonal methods. It's about taking pills. Et il y a aussi la pilule du lendemain. in case there has been any unprotected sex. Women take some pills. Donc, le pharmacien normalement l'explique comment prendre, how frequent, like à quelle fréquence il faut prendre ces médicaments, ces pilules. Et puis, there are surgical procedures. Là, c'est plus invasif parce que là, c'est une chirurgie. There are iodine, tubal ligation, and for men, vasectomy. Donc, in this unit, we'll explore these 4 types of contraception, or these 4 methods. Je me répète, dans ces 4 méthodes, il y a des différents sous-types. C'est-à-dire, in the behavioral, we have these 4 types. In the barrier methods, we have, again, 4 different types of barrier method. And there's hormonal method et surgical procedure. These are for female and this one for male. Dr. Lisa va nous expliquer. Vous me dites si le son est bon. Can you hear it?
No, madame. No.
Ok. Ça veut dire que je dois share. Là, c'est bon?
Oui, madame, là, c'est bon.
Hello and welcome to Health and Heals with Dr. Lisa. If you are sexually active and not ready to become a parent yet, it is important to use birth control to protect yourself from pregnancy. So this is something I am really excited to talk to you about today, because this is something basically I do every day with my patients. And for men, it's kind of simple because you use a condom or you can get a vasectomy. You don't really have as many choices as women. But for women, there are a lot of birth control options, which I love because, every woman is different. And so one may not work as well for the other one. So that's why it's really important to know there's different options. And I have women coming in and I do consultations all the time. So I'm so thrilled to do this today. Okay, there are 3 main types of birth control: barrier methods, intrauterine methods, and hormonal methods. Barrier methods are what we're most familiar with. These include products that block the sperm from getting to the cervix and usually include non-oxidil 9 spermicide, which will help make it more effective. Now, there's other things that are barrier methods like a diaphragm, and women come in all the time. Now, this one has a hole in it. Obviously, it's not going to work with hole. These are the type of diaphragms that we fit women with. So what happens with the diaphragm is that you come in, because this has to go around the woman's cervix. That's why the failure rate is actually pretty high. It's 18 to 20%, because you have to get it in the right position, and then it needs to be left in for a time period afterwards. So sometimes it can get uncomfortable, it can cause bladder infections. And so because it has a low efficacy, this is good for like a couple that's together and they're okay if maybe they get pregnant, but they just don't want to get pregnant right now. So what we do, a patient comes in and we place this vaginally, so it's flexible like that. And we fit it over the cervix. We show the patient how to do it because the end of your cervix feels like your nose. And then we fit them with the largest size. They come in different sizes, the largest size that's comfortable. So again, that's the diaphragm. And there's also a female condom. I don't have an example of that today, but its failure rate is 21%. And again, that's because of positioning. There's usually in failure rates, we predict like a typical rate and perfect use rate. So perfect use is if you were doing everything correctly, and then typical use, which is the one you really want to look at, because that's, say, you don't put it in the right place, you don't leave it in for the right amount of time. That's the failure rate. That's really what's going to happen. All right. And then spermicides are not necessarily 100% useful in preventing STDs. They can provide some STD protection, but you can't rely on them. That's why you do want to use a condom with spermicides. Now, intrauterine methods, or IUDs, as a lot of women call them, and it's become very popular, is implanted by your gynecologist. It's really easy, it's really quick, and it's hugely effective. It has a failure rate of 0.8% because it takes out the typical use failure rate, because you don't have to, it's placed, you don't have to do anything or get anything right. So there's two different kinds. There's a copper IUD, and it works by copper. Okay, it causes an inflammatory sort of reaction in the uterus that's kind of hostile to sperm. And then there's also the levonorgestrel kind, or the progesterone type of IUD, which is also very effective. And again, that works by a bunch of different methods, by increasing the density of the cervical mucus, again, by causing changing the lining of the uterus, and by suppressing ovulation as well. So it has kind of a threefold way of working, but they're both great. They can stay in for a long period of time, and they can be removed at any time. So these are very popular now, and they're very, very good. Now, there's also hormonal methods, and these release a combination of progestin and estrogen. And there's many pros and cons of hormones, and there's many different kinds. There's the one beautiful thing is there's so many different kinds. There's patches, injections, implants. There's oral. The implant is here, and basically one that you'll see, besides like an IUD implant, is an implant that you can put in your arm, and it's about this size. And basically, you just place it under the arm, and you can feel it. So that you have to know too. But it's very good. The only thing is it's very difficult to remove. It's really easy to place. It's very difficult to remove, but it's very good. And then there's also emergency contraception. So if you have one of those nights where you have a little oopsie, the condom breaks or something like that, then you can actually a lot of times go to your pharmacist and ask for Plan B without a prescription. You do want to follow up with your gynecologist about STDs, because if you didn't have any protection, you're also exposure for STDs besides pregnancy. So you do want to follow up with that as well. You can actually formulate Plan B with your own birth control pills, but depending on the what dosage of birth control pill you have, it depends on how many pills you can take, because Plan B is pretty much the same thing, estrogen and progesterone, just the same thing you have in your birth control pills. So a lot of times you can call your doctor and say, I can't get to the store, but this is the birth control pill pack I have. How can I make the simulation of Plan B that way too? So those are important things to know. You can do that yourself, but in conjunction with the doctor. Okay, and then I hope you really enjoyed this information. Oh, one other hormonal way is a vaginal ring. And this is really good. It can be left in for 3 weeks, and you take it out when you get your period. And so this is not a barrier method. This actually has hormones in the ring. And so again, that's another form. If you can't really take a pill, or you don't like to remember taking a pill every day. So the thing is, there's a lot of options for women to take control over their fertility. Okay, so for more information, talk to your OBGYN or visit the CDC's contraceptive website. I'll post the link below, and I hope this video was helpful. If you have any questions or comments, feel free to submit them in the comments below or on my Twitter or Facebook page. Thanks for tuning in, and as always, I'm Dr. Lisa, reminding you to be well and be fabulous.
Okay. Okay, donc you can have this video, I mean, on YouTube by looking for Dr. Lisa on contraceptive method. Donc, pour résumer, Dr. Lisa n'a pas couvert tous les types de contraceptifs parce que le but, c'est behavioral methods. She won't explore it because it's changing our behaviors. It's just, c'est-à-dire là, ce sont des choses qui sont pas à la pharmacie, sont on téléphone au docteur pour savoir quel type de méthode utiliser ou bien qu'est-ce qui est approprié, dépendant ce qu'on attend. Are we protecting ourselves or are we preventing STDs or preventing unwanted pregnancies? Donc, quand on explore tout ça, on regarde quels sont les avantages, c'est-à-dire quels sont les inconvénients ou est-ce que ça nous protège contre les STDs, par exemple, hormonal methods don't protect against STDs. La meilleure protection, c'est the barrier methods or surgical method, but sometimes it works, sometimes it doesn't work. It's not 100%. And quels sont les inconvénients d'utiliser le surgical procedure? Could be costly, could affect the health of the person. Donc, il faudra considérer tous ces avantages ou inconvénients quand when we opt or when we are, par exemple, si on fait une campagne de sensibilisation pour mieux informer, il faut savoir qu'est-ce que ça peut apporter, comment ça peut protéger les personnes, mais en même temps, quels sont les inconvénients. OK. Before we jump to the next part, moi, je vous conseillerais, parce que c'est bien plus en détail dans votre manuel, d'explorer les différentes méthodes qui expliquent un petit peu sur les méthodes et aussi, comme j'ai dit, sur les avantages et disadvantages of each method. Et puis, il y a a reading article that further explore these contraceptive methods. Let me see if I have a manual here. Any question till now?
No, madam.
Okay, thank you. My screen is frozen. Can you hear me?
Oui, madame, c'est bon.
OK. Donc là, c'est clair. You read on the different methods. Mais pour la révision, c'est facile. C'est de faire un mind map of different contraceptive methods et de diviser, par exemple, behavioral en 4 et barrier method, toujours en 4, et puis hormonal method et surgical, what are the advantages and the disadvantages, the risks, and par exemple, it's easy or at no cost, c'est économique. Là, c'est coûteux, par exemple. Ça sont les exemples. How to can you please mute yourself? Ensuite, in your manual, there is a section on pregnancy, because when we talk about sexual health, we talk also about pregnancy. Pregnancy concerns both the male and female, because pour la conception d'un enfant, il faut qu'il y ait both male and female. And pregnancy. When I say male and female, I mean both partners, including diversity. Donc, what are the psychological changes that are experienced by women or by female partners during pregnancy and after pregnancy? What are your ideas of the we'll expand it to include the psychosocial changes that are experienced by women during pregnancy and after pregnancy. Dites-moi un petit coup. What are the psychosocial changes? Anyone? You can refer, if you're parents, you can refer to your own experience, or if you have siblings who are parents, you can refer to the experience, like how you viewed them at that time. C'est-à-dire during pregnancy, what are the signs? I'm not talking about physical changes. I'm talking about psychological and social change. Because pregnancy impact not only our health, but also our emotional health, our mental equilibrium, our relationship with others. Allez, dites-moi.
Madame, la personne
You
peut
can-
être
dites-moi s'il vous plaît.
la personne peut avoir des changements d'humeur à chaque instant.
Ok, on va... The mood change.
On peut avoir baby blues.
Yes.
Les alimentations aussi, madame.
Okay. Nutrition, mood change.
L'impact sur le changement du corps. Sexual drive aussi. Ça veut dire, là, on a mélangé. Et ça peut se passer during the pregnancy or after the pregnancy. The baby blues is mostly after the pregnancy, which we call it postpartum depression. They're feeling low, sometimes feeling disconnected from the baby, like se sentir coupable de ne pas être a good parent because on n'arrive pas à gérer les pleurs, la demande d'attention, the need of a baby and our need for sleep or to take care of ourselves. Donc, il y a the guilt en même temps et puis il y a une déconnexion. Et puis, the change in your responsibility now as a mother, c'est un rôle additionnel as a parent, even for a father. Donc, le partage, parce que là, ils étaient à deux, c'était une relation à deux. Maintenant, il y a une troisième personne. And the relationship dynamic has changed because we are focused on the baby, on the child, who takes most of the attention. Donc, the dynamics has changed. Et avant qu'on s'adapte à cette nouvelle personne qui est dans la vie du couple, ça cause un débalancement. Donc, a period of adaptation. Donc, il y a pas mal de changements, il y a pas mal de choses qui se passent during and after pregnancy. Because after pregnancy, c'est-à-dire after childbirth, là, on négocie aussi les rôles, qu'est-ce qui fait quoi. Are we sharing the responsibility or is it 50-50 or is it one's doing most of it or one's not feeling, c'est-à-dire, bon, ça va dépendre. Et aussi, is there a presence of extended family? Is there a presence that's helping the new parents or interfering in their way of in their parenting style, c'est-à-dire imposer, c'est-à-dire les grands-parents qui imposent un petit peu ou qui donnent leur avis, où il n'y a pas la présence des grands-parents. Comment ça impacte their parenting skills?
Do you want to add anything? Since it's about our module is on sexuality and health and l'impact donc the pregnancy on the sexual libido of a person of both partners, because there's been a change in the body, comment on s'accepte soi-même et how the other partner see their new parent. Donc là aussi, c'est un temps d'adaptation, d'acceptation, de changement.
Madame, on peut dire que la maman est restless most of the time.
Yeah.
High BP.
Donc, physical health maintenant. Physical health also is impacted with the blood pressure. Ça peut être, on va dire, high. Hein? Oui, le physical health does have an impact on the mental health of a person. C'est-à-dire BP, high BP or low BP, high sugar level, especially during pregnancy. S'il y a des conditions médicales prior to pregnancy aussi qui peuvent jouer.
Donc, physical health does have an impact on the psychological health of a person. Parce que là, on considère. N'oubliez pas, when we are looking at this, we can think of a biopsychosocial because each has an impact. Each aspect impact the other aspect. The biopsychosocial, biological impact on the psychological, social impact on the psychological, psychological impact on the social also. Ok. Pourquoi c'est important de savoir tout ça? C'est parce que when you are a social worker, you may work with people who are pregnant. You may work with diverse population if you become if you will be working with patients or clients in the medical settings. On parle de clinical social work, but also for NGOs and all that, you get people who might be pregnant or thinking about building family, tout ça. Il faut savoir ces changements-là parce que eux, peut-être, ils ne savent pas pourquoi ils ont these kinds of problems, why they have mood change, why they are feeling low, etc. Donc, comprendre ce qui se passe peut aider. Then you might do the psychoeducation of your client. To do a psychoeducation, you need to know first. Then we do psychoeducation. Donc, let's see the manual. Let's check if we are on the right track. Donc, unit 3, on fait contraception. History you can read, history of contraception. History is just for you to know how contraception came about, but the most important part is for you to know the method. This is the practical part, c'est connaître les différentes méthodes et les différents types sous ces méthodes-là. Then we explore pregnancy. Then there's also abortion. Abortion in Russia is illegal, but in some countries it's illegal, and you need to know. Et puis il y a le STI or STD, sexually transmitted infections or sexually transmitted diseases, sexual dysfunctions, et puis variation in sexual behavior. Quand on parle de variation in sexual behavior, là, tout ce qui est disorders. On a parlé de la définition sexual health, contraception. Donc, this is quite straightforward. Donc, un avantage du behavioral method face aux autres, c'est que ça ne coûte rien. Changing our behaviors does not cost in terms of money. Barrier methods in some countries, or maybe in Mauritius also, there are NGOs who provides for condoms. Et puis le hormonal method. But hormonal method does have an impact on the physical health, like the side effects, reduce sexual interest, arousal, nausea, headache on women's health, and vary largely as each woman's body is unique. Puis il y a le emergency contraception. Le surgical est le plus coûteux. Il y a 3 types de surgical: IUD, dual ligation, and vasectomy. This is for women. Okay, this was about the contraception. Et puis, on a vu, let's see about pregnancy. One common change is depression. Changes in sexual interest and behavior also. Et puis là, on parle de surtout si there are birth defects. How does it affect parents, both partners, knowing that their baby might have some defect or disease or impairment. Parle aussi de miscarriage. Okay. This was about pregnancy. Now abortion is an unwanted pregnancy. Abortion can take place with medication during the first few weeks of pregnancy. But in later phases, it requires surgical procedures. Donc, emergent abortion is illegal, except in cases where the life of a mother is in danger, or in case of incest or child rape. Donc, quand on parle de sexuality, we talk about sexual health, but we also talk about sexual risk. C'est ce qu'on appelle high risk behavior, quand on ne se protège pas, and we are at the risk of contracting infections. Il y a différents types d'infections. Bon, these figures are, c'est daté de 2008, but they are the latest ones. If you look at on the website, on the WHO, different figures on prevalence of STIs. Donc, ce qui est important de savoir, c'est le sexually transmitted infection can be contracted through sexual intercourse, c'est-à-dire male-female, but also through oral genital and anal genital sex. Là, c'est casse un peu les mythes que only through unprotected male-female sexual intercourse we can contract STI. No, we can contract also through oral sex or through anal sex. These infections can be categorized in bacterial and viral infections. Là, vous avez toute une liste des différents types de STI, quelles sont les causes et s'il y a des traitements ou pas. Donc, il y a gonorrhea, syphilis, chlamydia, genital wart, herpes. Il y a une série qui s'appelle Chlamydia sur Netflix. Je ne sais pas si c'est toujours là, Chlamydia. It's about a young man who contracted this STI. C'était assez monotone la série, but it was interesting, like to show how lifestyle you can contract a disease
through your lifestyle, like carefree, no protection, multiple partners, and you don't know where you contracted this disease. Donc, mais il y a des antibiotiques. Donc, mais il faut savoir, but if it's untreated, it may lead to serious consequences. AIDS. This we have a unit on AIDS. Unit 5 is on AIDS. There are very good treatment, but treatment should be regular, should be followed regularly. No cure, but someone with HIV might delay the development of AIDS, but they need to regularly follow up their treatment. Donc ça, c'est un petit peu les différents types de STI and their causes. Donc il y a aussi les mythes. You can read it to know that about the different myths on sexuality. Donc, like for instance, you cannot get the same STI twice, c'est faux. Ok, donc this was about STDs. Et puis il y a le sexual dysfunction. Quand on a fait lifespan development regarding sexuality, among older adults, on avait vu que there is sexual dysfunction and also death of one partner, which impact on the person. Donc là, quand on parle de sexual dysfunction, it's not just for the elderly. It can be anyone, any adult. Donc, Life, Lohman, Pegg, and Rosen found the following factors associated with the risk of sexual dysfunction. Quels sont les risques de sexual dysfunction, sorry. What are the risks of sexual dysfunction? There are emotional problem and stress might impact the sexual drive, the libido of a person. As I said, both men and women. In men, poor physical health are correlated to greater risk for low sexual desire or erectile dysfunction. C'est-à-dire pour physical health, for men, emotional problem, stress for both men and women might cause or might be linked with sexual arousal difficulties. Et puis s'il y a abus aussi, before puberty, for both men and women, there might be some sexual dysfunction. Et là, on voit que women who were previous victims of sexual assault were more likely to experience arousal disorders. Men who reported having forced themselves on a woman before were more likely to experience erectile dysfunction.
Donc, si on a résumé ça, c'est factors, si vous avez une question, what are the factors associated with a risk of sexual dysfunction, emotional problems, stress, poor physical health for men, lead to low sexual desire, but for women, its poor physical health might lead to a painful sex. Et puis, les abus, sexual abuse can impact on arousal, might have impact on both men and women in terms of arousal disorders. And women who are victims might have arousal disorders, while male perpetrators might experience erectile dysfunction. Having a sexually transmitted infections in the past might lower the sexual desire over libido over women. Abortion, là, c'est unrelated, c'est-à-dire having had an abortion was not related to any sexual dysfunction in women. Masturbation was unrelated to sexual difficulties in both men and women. Donc, these were about sexual dysfunction. Et là, j'avais parlé du DSM, the Diagnostic Statistical Manual of Mental Disorders. Ça, c'est 5. Maintenant, depuis 2022, we have 5 text revision. This is the latest. Donc, there are different types of sexual dysfunction which are enumerated, but you are not expected to know them by heart. Just for your knowledge, vous pouvez les lire. So, the different types of sexual dysfunction, delayed ejaculation, etc., etc., etc. Donc, sexual dysfunctions can have various causes. It could be biological, social, psychological. Donc, dépendant des causes, si c'est social, psychological, then we intervene. But if it's biological, then it's a medical practitioner. Donc, apart from pharmacotherapies, psychological therapies for sexual dysfunctions include the cognitive behavioral sex therapy, instructing the clients to modify their behaviors. Donc, variation in sexual behavior. Donc, there are norms in each society, and when we deviate from our norms, from our social norms, from our cultural norms, c'est ce qu'on appelle un semblant de normalité dans la société. Mais si ça, if it's deviate from the norms, it's called paraphilia. Donc, psychiatrists have identified a range of disorders named as paraphilic disorders. Donc, paraphilic disorders, c'est quoi? C'est, according to, c'est le DSM, according to American Psychiatrists Association, most people with atypical sexual interest do not have a mental disorder. To be diagnosed with a paraphilic disorder, DSM-5 requires people with these interests to feel personal distress about their interests. C'est-à-dire, pas juste parce que la société désapprouve, mais they feel a distress about their interests. Deuxièmement, have a sexual desire or behavior that involves another person's psychological distress, injury or death, or a desire for sexual behaviors involving unwilling persons. Ça, c'est le
contre le consentement. C'est-à-dire, pour avoir un paraphilic disorder, il faut qu'il y ait ces deux choses-là. C'est on se sent vraiment mal, personal distress about this. And secondly, it involves, c'est-à-dire, il n'y a pas le consentement d'une autre personne. So someone else might be in distress. These are the different types of paraphilic disorders in the DSM-5. Mais bon, le DSM, it's modified after some years. Parce que le DSM, comme j'avais expliqué, c'est un groupe d'experts, psychiatres, qui vont inclure ou modifier ou changer ou retirer certains types de disorder dépendant de la société en général. When I talk about society, it's DSM, it's mostly des pays développés. Auparavant, même le homosexuality was included as a disorder, mais par la suite retiré. Gender, comment on appelle ça? Gender identity, moi je cherche le terme exact. Auparavant, on parlait de gender dysphoria ou gender identity disorder. Maintenant, on parle de gender. Parce que les termes, ça change aussi. Le DSM, il y avait DSM 1, 2, 3, etc. Maintenant, on est à DSM 5, Text Revision, depuis l'année dernière. Donc, les termes aussi, ça évolue. Et aussi, les types, c'est-à-dire, auparavant, homosexuality was a disorder, now it's not. So maybe cette liste peut changer après des années. Donc, but when here, ce qui nous concerne plus, c'est ce qui est analysé dans le manuel, c'est le pedophilic disorder, sexual focus on children. Et quels sont les types de thérapies qu'on utilise? They are both medical therapies and psychological therapies. There's also social skills training. Bon, c'est tout ce qu'il y a in Unit 3. Donc, pour résumer, Unit 3, it's about contraception, pregnancy, abortion, STI, and sexual dysfunction. Donc, une question, why was homosexuality considered as a mental disorder previously and not nowadays? Because auparavant, la société désapprouvait et it was thought as something not normal. Mais maintenant, on a vu que it's both an interaction of genes and environment qui fait qu'une personne peut être attirée par the same sex partner. Donc, parce que avec l'évolution de la science et l'inclusivité, donc la société aussi, il y a awareness, il y a understanding, et la science aussi qui a évolué, les recherches, ça fait que voilà, avec les recherches, c'est plus les recherches parce que DSM, it's more about science, research and science. Donc avec l'évolution, on a modifié, on a vu que homosexuality is not a disorder. It's about an interaction of genes and environment that makes people feel attracted
anyone. Donc, je prends les questions. Allô?
Oui, madame. Une petite
Oui.
question. Et comment nous capable expliquer ban crime passionnel?
Un moment, Un moment, il y a docteur Goumani qui me dit qu'il y a des élèves qui m'attendent. Any of your classmates cannot have access? Est-ce qu'il y a un souci? Vous avez tous accès?
Oui, madame, en fait, j'ai un petit problème parce que j'ai une connexion pour la classe.
Oh, ok.
Mais,
Je vois, il y a 26 personnes là. Je comprends pas. Un instant, je reviens à vous, je réponds au message un coup parce que... On est bien dans la classe de Sexuality and Health, right?
Oui, madame.
Ouais, mais c'est bon. Laissez-moi retirer une photo moi aussi.
madame, en fait, avant qu'on connecte le Blackboard, je peux join, ça veut dire join session direct et je peux finir en de la classe. Mais cette fois-là, je me trouve classe 4. Capable madame, besoin join la classe 4 là, et là, je peux rentrer en classe aujourd'hui.
Yeah, like
Au fait, tu me penses une rentre de classe.
Pardon, redites-moi.
Il y a 2 classes. Une room 4 avec une online. Peut-être je rentre de première là. Parce que tout à l'heure, bon, c'est même cette confusion là.
Ah, ok. C'était une semaine de cela, I sent the direct link to the class. Vous avez reçu.
Good morning, Dr. Shah.
Hello, Dr. Gumani.
Good morning, everyone. I'm sorry. Which room they should join in. If you have a WhatsApp group, could you please just send there that they have to come in room 4, please?
I don't have a WhatsApp group with students.
The students have a WhatsApp group, if they could communicate the same, because some students have been waiting there.
Y a-t-il the class captain? Is there a class captain in class today?
On peut mettre. Là, je vais essayer quand même de mettre.
D'accord.
Merci. Doctor, I won't take much of your time. I'm leaving the class, okay? I apologize for the messages because I was in that room too. Okay, good day.
Merci. Thank you. Thank you. Ok. Il y avait une question. Vous pouvez me reposer la question?
Oui, madame, excusez-moi. Au fait, pas sur un crime passionnel. Comment nous pouvons définir un crime passionnel? Parce qu'il peut bien assez courant dans Maurice.
Dépend quelle perspective qu'on prend pour analyser crime passionnel. Est-ce qu'on prend vraiment, ça dépend de perspective qu'on prend.
Excusez-moi, madame, c'est-à-dire nous pouvons dire que le sexual drive là-dedans?
Non, crime passionnel, là, il plus l'agressivité, c'est-à-dire agressivité par rapport à si nous allons théorie Bandura, if you look for Bandura's theory of aggression, pour trouver un petit peu agressivité, comment nous avons expliqué. Les cas expliqué par et plus par rapport à la imitation, mais aussi à ne pas capable de contrôler l'agressivité des fois. Mais maintenant, quand je dis différentes perspectives, ça veut dire, surtout dans la psychologie, nous prenons différentes perspectives. Et d'après perspective qui nous prend, nous avons expliqué. Par exemple, agressivité. Quand nous pouvons analyser l'agressivité, as social worker ou as therapist, as someone who is in the psychosocial field, quand nous analysons quelque chose, souvent c'est avec plus de compassion parce que là, nous analysons sur earlier experiences et pas juste le présent, nous analysons sur early experiences. Et aussi, qu'est-ce qui a poussé cette personne à un temps d'agressivité? Parce que, je vais donner un exemple. J'étais dans I was in a workshop et on posait la question à un expert. On lui disait, yes, we need to have compassion and all that, but what about perpetrators? What about those who have killed people? Il nous a expliqué, yes, this aggressive. Là, on parle de, like each one of us, we don't have just one personality. Je ne vais pas dire que vous avez des multiples personnalités, but we have different parts of us. Like we have one part of us who can be very caring for someone, one part who can be aggressive, one part who can be very très convivial, très amical. Donc we can be many different parts. C'est-à-dire on a différentes parties de nous. But there is one part who can be very aggressive, like we have to protect something. We have to protect ourselves. Mais des fois, on ne comprend pas if we don't analyze ourselves. Mais les crimes passionnels, ça, il y a plein de théories. Je ne suis pas spécialiste in this field, but vous pouvez faire des recherches pour comprendre qu'est-ce qui fait que les personnes tuent les autres personnes. Surtout, là, when we talk about des crimes passionnels, il y a un attachement avec la personne et cet attachement a été peut-être brisé ou a été confiance ou là je parle, ça peut être relationnel, ça peut être la personne a un souci, could be, depends on the person. On ne peut pas généraliser toutes les personnes. C'est-à-dire l'expérience d'une personne, their experience de la vie avec une autre personne, son expérience, comment il perçoit, how do they perceive the world, is it threatening that they have to fight, c'est-à-dire ils doivent combattre pour avoir les choses. Donc vraiment, donner une opinion sur quelque chose de général, c'est difficile, surtout if we work with people, individual people. Like, pour nous, c'est le cas par cas. Par contre, si je parlais des recherches, ça allait être différent. Like, we compare, we analyze, we look at patterns, c'est différent. Moi, ce que je vous conseillerais, si vous voulez comprendre why people, quand on parle de comic crimes, c'est sous le thème d'agressivité, aggression. Why do people become so aggressive? Surtout les théories de Bandura qui cut across many things. Parce que Bandura avait fait ses expériences on children first, experience. C'est-à-dire, il avait mis les enfants là à observer in like a laboratory. C'était vitré. Il avait une télé, montrer une vidéo où quelqu'un frappait un nounours. Et on a vu que l'enfant imitait. L'enfant aussi frappait le nounours. Là, c'était le début de ces études sur l'agressivité qui est quelque chose, c'est imitating, observing and imitating. Ça, c'est pour les enfants. Mais par la suite, il a fait plein d'études sur aggressiveness. Pourquoi les personnes deviennent agressives. Par contre, les animaux, c'est instinctif. Animals, c'est pour protéger. Mais we do have this animal part also, mais notre cerveau est bien plus complexe. We can stop notre agressivité, mais ça dépend. Donc, if you want to take l'aspect neurosciences, ça explique l'agressivité d'une autre manière. C'est-à-dire, si vous demandez différents experts, vous allez avoir différents points de vue qui va compléter votre aperçu de pourquoi cette agressivité. Donc, il y a, on nous dit, can homosexuality be man-made, not in the genes? Mais ça, je ne peux pas répondre parce que normalement, les études nous disent que it's both. C'est une interaction en genes and environment. Mais je ne veux pas dire que c'est que l'environnement ou c'est que the genes, because that would not be professional.
But it can be at certain point in time, like surtout, pas surtout, mais des fois pendant l'adolescence où, enfin moi, j'ai vu, like when I work with adolescents, there are some trends, like LGBTQIA, it's kind of trendy sometimes at certain times, trendy, and many will have same-sex partners for a short period. And then, quand c'est plus le trend, they go back to being heterosexual. But it can happen, can be trendy, but as therapists, on va pas généraliser le cas. C'est-à-dire que juste la personne va découvrir, c'est la personne à dire if they are LGBTQIA or straight people. Nous, on ne peut pas dire it's man-made or genes. Non, ce qu'on peut dire, c'est ce que la science nous dit, c'est l'interaction entre genes et environment, c'est-à-dire l'environnement où on vit. Mais aussi, il y a le genetic part. Quel pourcentage, on ne sait pas. Mais on sait que c'est les deux, l'interaction des deux. Maintenant, nous, on ne peut pas être judgmental. Quand une personne vient, on l'écoute, we build up this therapeutic rapport, we listen, and we let them explore themselves, know themselves, understand, analyze. C'est-à-dire, ils vont comprendre est-ce que c'est eux, et c'est leur propre désir d'être comme ça, ou c'est les autres qui leur disent « Ah, tu es garçon manqué, sûrement que tu es comme ça. » Parce que these are messages sometimes adolescents entendent parce qu'ils sont garçons manqués, parce qu'ils sont plus féminines que les autres, qu'ils doivent forcément être gays ou homo, comme on dit. Mais quand ils viennent vers vous, c'est à eux d'explorer, de comprendre, is this what I want or is this, ce sont les messages que je reçois ou c'est quelque chose que je veux? C'est nous, notre rôle, c'est d'éclairer leur façon de penser pour qu'ils puissent comprendre ce qu'ils sont. But we don't impose, we don't lead them, we just les éclairer pour qu'ils comprennent. Parce que si on est maladroit, we can be seen as des thérapeutes qui ne sont pas ouverts d'esprit, qui sont fermés ou qui sont, comment dire, homophobes. Vous voyez? Parce que notre rôle, c'est toujours d'être compassionate, empathy, understanding, but also in doing psychoeducation, c'est éclairer, expliquer. Mais ça dépend quel moment. We don't every time do psychoeducation. There is a time to do psychoeducation when you feel the time has come. Parce que dans une session, il y a la phase où on écoute, we build un rapport, on écoute, mais il y a un temps pour aussi expliquer ce qui se passe. Donc, this was it. Alors, il y a une question. Can perpetrators have cultivated a criminal mind since childhood if his childhood was not treated after a trauma? Trauma, c'est quoi trauma? Trauma, c'est pas seulement les abuse, violence, war. Trauma can be many things that we don't realize. Comme j'avais expliqué, big trauma, small trauma, they're all trauma. Trauma, it does impact our perception, how we perceive things, and depending on how traumatic it can be, ça veut dire si un traumatisme, une personne a eu un trauma étant très jeune, c'est-à-dire enfant, ça peut impacter sa personnalité. Like, they can develop certain disorders. For instance, borderline personality disorder or bipolar, or multiple personality. Mais si c'est avant un certain âge, surtout là où l'enfant est en train de développer, they might have certain disorders. Là, je parle de disorders. Mais pour devenir perpetrators, it does not depend on whether there has been a traumatic experience. Parce que certaines écoles de pensée disent que to be a perpetrator can be a choice because you choose to act on your feelings. You choose to act. Violence is an act. C'est pas juste une pensée, une émotion, but it's an act. Et before a behavior, there are thoughts and emotions. Donc, agir, c'est aussi un choix. Ça, c'est une école de pensée. Maintenant, il y a une autre école de pensée qui dit que can it be a choice if, c'est-à-dire, their perception of the things are distorted? Is it really a choice? But not all sexual abuse victims become abusers. Pourquoi certains deviennent some become abusers, others not. Donc, on ne peut pas dire que being a victim of child sexual abuse, you will become a perpetrator. No, it's not a direct link. Maintenant, c'est tout le temps le cas par cas. We cannot generalize things in this case because if we do case histories, we analyze case by case. If we are doing a research, then it's different. Mais pour faire des statements like can perpetrators become criminal, cultivate a criminal mind, we have to analyze the data. I wanted to ask questions.
Oh, qu'est-ce qui s'est passé? Excusez-moi. Oui, merci. Alors, tunnel vision on the presenting issue is referred to by narrative therapists as. Je disais que tunnel vision, c'est quand les clients sont là, ils vont vous parler de leur concern, what's affecting them, and they will tend to focus on what's wrong. That's tunnel vision. They come here with their issues. And the narrative therapist will listen, but also will ask questions to clarify whether they have understood. But also they will expand on the stories. And how do they expand? Through their questions. Their questions will highlight also moments where the client showed strength, showed competency, showed skills in dealing with their problems. C'est-à-dire que vous, en tant que social worker using narrative therapist, when you have a client with any issues, you will first build the rapport, establish the rapport, you will expand, you will build a therapeutic rapport, you will collaborate to set the objective of the sessions or the session over sessions. You will ask questions to understand the problem from the perspective of the client. You listen to them, to their story. You will use counseling skills like listening, paraphrasing, validate their emotions and all that. But then you will try to expand their story through your question. Expanding their story means you will ask about, est-ce que vous avez eu, par exemple, vous avez eu ce souci-là auparavant? If it's about fits of anger. Have you experienced any fits of anger previously? Ils vont dire oui ou non. Ben, si c'est oui, but how did you deal with that? Ils vont vous expliquer ce qu'ils ont fait. But can you do that again? Can you do that again and we'll see what happens? So you're highlighting that they had a method of dealing with their issues previously. Maybe it's not working now. This is one type of highlighting their competency or skills that they already have. Or vous pouvez répondre à la question entre-temps because you have used it in your assignment. Donc, tunnel vision is like they focus on, their focus is on their concern, on what's bothering them. And narrative therapists have certain terms that's used. Et c'est quoi? Allez, vous avez 5 minutes. 5 minutes. On n'a que 3, 4, 5 participants pour le moment. En même temps, ça, on va faire quelques questions. En même temps, ça va vous aider à comprendre. Est-ce que vous avez compris ce qu'on a fait un peu?
I won't know whether, I won't be looking at whether you have got it wrong or right. It's for you to know. So, juste mettre la réponse, ce que vous avez appris during, c'est-à-dire pendant la session qu'on a fait, et aussi quand vous avez fait votre assignment. Est-ce que you can recall what's the answer? Ok, 5 secondes. Cinq, 4, 3, 2, 1. Ok. Bon, c'était Problem Saturated Stories. Problem Saturated Stories. This is the word we talk about stories in narrative therapy. Mais le terme utilisé by narrative therapists, c'est we talk about clients coming with their problem-saturated stories. So because they come in session, they will come with their story, but it's all about problems. Parce que aussi, c'est scientifique, ça. We tend to focus on what's negative. Il y a ce dicton qui dit que vous pouvez faire tant de bonnes choses pour une personne, mais il va penser à l'unique chose que vous avez mal fait. C'est la nature humaine, but it's also how our nervous system works. We tend to focus on the negative because we have a negative bias. C'est-à-dire que we tend to focus on what might go wrong. Let's do, yeah. Okay, Michael White, one of the founders of narrative therapy, he regards problems as something operating on persons rather than as something they are doing. He termed this as one, operational objectivity, as be externalizing, as extracting, or as dissociating. Michael White regards problems as something operating on persons. Ça veut dire, là, je traduis. C'est ce qu'il dit, Michael White. Et c'est lui qui dit au début, il dit there are problems. Problem is a problem, a person is a person. That people are not problem. Problem is something else, and the person is just a human being. Sometimes he said, we are recruited in the problem. And for this process, we tend to do what? To help the person understand that they are different from the problem. Et quand on fait ça, on a tendance à diminuer le defense system de la personne. C'est-à-dire la personne n'est pas sur la défensive parce que we don't associate them with their problems. We put a distance between them and the problem. C'est-à-dire la personne ne va pas se sentir inférieure ou ni déficit. Par exemple, someone who has contracted HIV, we dissociate that from them. We might say, how does HIV impact you? Like, how has it changed your relationship with your partner? Instead of saying how being HIV positive. See, we tend to put a distance. Allez, vous avez 1 minute. Moi, j'ai utilisé le terme, mais c'est fait exprès. You have to know what's the term we use to say we put a distance between the person and the problem. For our questions, we use we. Allez-y. Allez, 5 secondes. Alors, la réponse est bien externalizing. C'est ça le terme externalization. Externalization, c'est externalizing. Instead of internalizing the problem, we externalize. C'est-à-dire mettre une distance entre le problème et la personne pour que la personne se sente à l'aise, moins sur la défensive. And we explore how the problem-saturated story has certain impact on the life of the client. Okay. A last one. Donc, peut-être que, je sais pas, si vous avez fait la lecture, you might have come across this term of not knowing stance. Ça veut dire narrative therapists take the not knowing stance. C'est quoi le not knowing stance? C'est par exemple, c'est pour ça que je dis quand on fait une session, we don't know the experience of a client. Maybe we have heard we had similar experiences, or people around us may have had similar experiences, but still I don't know what my client is experiencing because it's from their perception. Et chaque perception est différente, c'est how they feel about it, etc. Plein de choses qui rentrent en jeu. Donc, not knowing stance is, even though I may understand the story, but I might not know it from the experience of the client. So I take the not knowing stance. Not knowing stance means I am here to listen. I listen and I try to get your worldview, your perspective, to understand what you're living, your emotions, your thoughts. And I try to, c'est ça, show empathy with what you are living. Allez, 2 minutes. Okay, let's see your responses. Okay. Well, say by not knowing, we don't know your experience, we listen to you, and through listening, we help you, clients, become expert in their own lives because we are listening. We give them that space to tell their problem-saturated story. We externalize through our questions. We do externalization. We externalize their problem. And we highlight their skills through unique outcomes. And so they become experts on their own lives. C'est quoi experts on their own lives? C'est-à-dire they know what they are living. They have, they understand their worldview, tout ça. Donc, we help them become experts on their own lives. Voilà. Some questions on narrative therapy. C'est à travers des questions qu'on peut comprendre mieux les choses. Donc, this is about sexuality and health module. Next session, c'est en novembre, right? On prend 10 minutes et puis on commence clinical social work. Any questions before we go? Note that il y a un autre lien pour clinical social work. Le lien que je vous ai envoyé, donc c'est dans Announcement. You can just click on it. You have direct access. Normally, I do send the link 1 or 2 days before, mais parce que j'ai limited access to internet, I have sent it on Sunday or Saturday. So, je vous revois sur le lien. Merci. À tout à l'heure.
Merci, madame.